Okay, now I'm going to talk about the management of infertility. Okay, first of all, you have to start with counseling the patient. You have to counsel the male and the female to tell them about their sexual habits, the frequency that they have to care about their body mass index, the influence of smoking on their fertility, and so on and so forth. Okay, then you have to move to treat the cause behind the infertility, and here we're going to talk in details. Okay, if we have a male factor infertility, then we have to treat the cause, the male factor infertility. If it was a hypogonadotrophic hypogonadism that causes the male to be infertile, you have to give this male a gonadotrophins. Okay, hypogonadotrophic hypogonadism means that there is some hormonal imbalance. Okay, there is no gonadotrophin that cannot stimulate the gonads to make the hormones. Okay, so we solve this problem by giving gonadotrophins. Okay, if the male has obstructive azoospermia, then we have to correct this obstruction by correction of epididymal block. If the obstruction was because of epididymal block. Okay, the third problem that could be is ejaculatory failure. Okay, sometimes we have a problem that is retrograde ejaculation. Okay, management of this ejaculatory failure will, of course, inshallah, solve the problem. So first of all, we have to counsel the patient, then we have to treat the cause behind the infertility. If it was male factor, then we have to find out what male factors that affect the infertility. If it was hypogonadotrophic hypogonadism, then we have to give gonadotrophins. If it was obstructive azoospermia, we have to correct the obstruction. If it was ejaculatory failure, then we have to manage the ejaculatory failure. Okay, what if the cause behind infertility was ovulation disorder, an ovulation disorder? Then we have to solve this problem too. Okay, what are the types of ovulation disorders? We have three types of ovulation disorders, or three groups of ovulation disorders. The first group is hypothalamic pituitary dysfunction. Okay, the problem is in the hypothalamic pituitary axis. So there are no hormones, no FSH, no LH, or low FSH and LH. This case is hypogonadotrophins because we have low gonadotrophins. Hypogonadism because the low numbers of gonadotrophins will lead eventually to low sex hormones. Okay, so this is the first group, the hypothalamic pituitary group. Okay, what to do in this case? In the case of hypothalamic pituitary axis dysfunction, group 1 ovulation disorder, we have to give a replacement therapy for these gonadotrophins. Okay, we have to give a pulsatile administration of gonadotrophins releasing hormones. Okay, or gonadotrophins. Okay, either you can give gonadotrophins releasing hormone or gonadotrophins. Okay, and you have to give luteinizing hormone to induce the ovulation. Okay, this is easy by logic. Okay, we have lack of gonadotrophins, then we can give gonadotrophins releasing hormone or gonadotrophins, and we have to induce ovulation by luteinizing hormone. What is the second group of ovulation disorders? The second group of ovulation disorder is hypothalamic pituitary and ovarian failure. Okay, the first group was just hypothalamic pituitary. The problem was in the upper centers, but here in group 2 we have hypothalamic pituitary ovarian failure, and the most important example of group 2 ovarian disorder is PCOS, polycystic ovarian syndrome. Okay, we will talk separately about polycystic ovarian syndrome in subsequent videos, but now I will give just some outlines about this, the treatment of PCOS. Okay, first of all, you have to lose weight. If your body mass index was or is over 30, okay, you have to lose weight. Then if losing weight is failed, we have to give clomiphene citrate. Okay, don't ever underestimate reducing body mass index in PCOS. More than 70% of the hormonal imbalance will back to its normal status after losing weight. Okay, clomiphene citrate is the second line of treatment after losing weight, or metformin, but don't give clomiphene citrate or metformin more than 6 months. Okay, if it doesn't work, clomiphene citrate, then you have to do laparoscopic ovarian drilling, laparoscopic ovarian drilling, and gonadotropin administration to induce ovulation. Okay, this is about PCOS, and I'm going to talk about PCOS in details in subsequent video. Okay, so what is the third group of ovulation or ovulatory disorders? The third group is ovarian failure. So hypothalamic pituitary, which is hypogonadotropic hypogonadism, first group. The second one is hypothalamic pituitary ovarian failure, and the third group is just ovarian failure with no problems in the upper center or in the hypothalamic pituitary axis. Okay, so we talked about treatment of the cause if it was male factor and if it was ovulatory factor or ovulatory disorders. What if it was a tubal and uterine factors? What if the problem is with tubes? One of the things that we can do is tubal microsurgery and laparoscopy, but until now no evidences of the effectiveness of tubal microsurgery. Okay, if we have a proximal obstruction of the tubes, then we have two choices. We can do salpingography with catheterization, or hysteroscopy with cannulation. Okay, these are two maneuvers to solve the proximal tubal obstruction. Okay, what if the problem was hyperprolactinemia? What if the cause behind infertility was hyperprolactinemia? Then we have to give something that reduce the prolactin, and as we all know that dopamine is the inhibitor of prolactin secretion. Okay, so we have to give dopamine agonist. Bromocriptine is a good example of dopamine agonist, bromocriptine. Okay, bromocriptine. If the cause of infertility was uterine adhesions, then hysteroscopic adenolysis is the surgery to do to lyse these adhesions. Okay, what if we have unexplained infertility? If it was, or if it is not male factor, not ovulatory disorder, group 1, group 2, group 3, if it is not a problem with the tubes or the uterus. Okay, and what if it is an unexplained infertility? Okay, if it is unexplained infertility, we have to try to conceive for 2 years with regular unprotected sexual intercourse. The first thing to do is to give the couple the chance to conceive, okay, within 2 years of regular, unprotected sexual intercourse. If we fail to conceive in the first 2 years, then we move to other things like in vitro fertilization. In vitro fertilization, we talk about this in other video. Okay, this is headlines about how to manage infertility, and I just want to tell you about something we call intrauterine insemination. Intrauterine insemination, which is introducing a semen or sperms in the uterus. Okay, when do we do intrauterine insemination? When there is very difficult situation to have a sexual intercourse or vaginal sexual intercourse. Okay, this is the first case. The second case, in patients with HIV, for example, they have the sperms should be taken and should be cleaned from the virus and then administered to the female, and this is done via intrauterine insemination. Okay, and you have to make sure that you don't do intrauterine insemination if you have mild endometriosis or mild male factor infertility, or if you have an unexplained infertility. Don't do intrauterine insemination. Okay, don't do intrauterine insemination. I forgot to say that in cases of endometriosis, okay, I will explain that in a separate video talking about endometriosis. Okay, but keep in mind that endometriosis is an important cause of infertility, and the treatment of endometriosis will be explained in another video. Thank you very much for watching. I'm sorry for my mistakes. Okay, see you in the next video. Thank you very much.